Good morning, everybody. I would like first to thank all organizing committee for All Indian Society for the invitation, and it's always a great pleasure and honor for me to participate in this honorable meeting and Congress. I would like to summarize the very strong session that we already heard and the marvelous presentations of dear colleagues, that retinal vasculitis can be either artery or vein or both of them, and angiitis, and sheathing of the vessels, which leads to leakage and occlusion, is the pathogenesis. It can be primary cause of ocular vasculitis, infectious or autoimmune, and we should consider other causes as AIOS disease, previously presented with our dear professor, Ervan, intermediate uveitis, frosted angiitis, and the birdshot retinopathy. Immune vasculitis is also very common, and we don't forget that multiple sclerosis can present with neuroretinitis, which is very, very important, and we pick as ophthalmologists these patients of multiple sclerosis, Behçet, sarcoid, systemic lupus, as we previously seen in previous presentations, as well as Vogt-Koyanagi, we'll never forget it, and rheumatoid arthritis, juvenile arthritis. Masquerade syndromes, I'm highlighting it because it's very, very important, and we save the patient's eye and life. Both can be saved by the ophthalmologist. Don't forget that retinoblastoma, malignant melanoma, lymphoma, as we've seen in a very, very good presentation, I really admired it. Leukemia and the metastasis is very, very important causes to present with the ocular inflammatory symptoms and signs. Infectious vasculitis, if we'll go deeper, it's either bacterial, viral, or parasitic, as we all know, and this will never be forgotten, but syphilis, as I heard, because I personally didn't meet, I am now working for 25 years, and I didn't meet a case of syphilis in Egypt, but it should be put in the back mind, because as the very, very good slide that I photographed, that it can present with the many presentations, especially the subretinal dense exudation and the whole retinal retinitis. So these are very, very important points. Infectious vasculitis as a pathology will go in several stages of infiltration and inflammation, which present with cystoid macular edema, uveitis, and signs of inflammation. Stage of ischemia, never forget it, because this we might search for it, especially in the indication of fluorescein angiography, and the stages of complication, neovascularization, and later complications of glaucoma, tractional detachment. And to summarize the pathology, whether it's a vein, artery, or both, and we can go for the provisional diagnosis for the etiology in these conditions. Retinal vasculitis will present with posterior uveitis, neuroretinitis, or in the stages of complication, vitreous hemorrhage, rubiosis, and vitreoretinopathies. If it is an artery, it will present more with attenuated vessels, sheath vessels, cotton wool spots, and ischemia. If it is vein, it will present with retinal hemorrhages, as we have seen, and retinal edema, more microaneurysm, and telangiectasias. The battery of investigations should be according to the provisional diagnosis, according to the clinical sense. And some of my pictures, I will renovate the previous presentations. This is a child after, of course, the patient's consent of approval to show the photos, because he's presenting with complicated cataract, corneal opacities, and as we can see, poliosis and vitiligo, and the complicated cataract with also the skin manifestations of depigmentations. And if it's clear media, we can see the classic picture of the milky white posterior pole of Harada, and it's more obvious with fluorescein angiography. The frank documentation with the OCT, the lacunae in the intraretinal cystic edema. This is frank pathognomonic sign of Harada in these conditions. And to see a patient with vasculitis, vitritis, media, haziness of the media, especially if in the middle age group, going for fluorescein angiography will reveal and highlighting the vasculitis, the staining of the vessel, and the peripheral ischemia in these cases. And case of Behçet is, of course, very pathognomonic in these conditions. Obliterative vasculopathy will be immune, autoimmune disorder, and we'll go for the hematological assessment of the patient, especially in young age group. And this is another case of obliterative vasculopathy, but it's a bit old with the ischemic changes in the retinal periphery. Hemorrhagic vasculitis can also present with the pre-retinal dense hemorrhages. Frostatitis is rare, but it can be found in children and young adults. Of course, multiple infectious agents are suspected, and especially in cases with familial Mediterranean fever, and they respond dramatically to steroids. The frostatitis with the vasculitis and the hemorrhages around the vessels are very obvious. Vasculitis and optic neuritis can be seen, and here is the sheathing of the vessel walls or through the retinal periphery, and more obvious, the edema, disc edema, and macular edema of fluorescein angiography. If we see in the peripheral candle waxing and sheathing of the vessels, especially in the periphery, and this case was proved to be a periphlebitis, and after chest X-ray, the bilateral hilar lymphadenopathy proved to be a sarcoidosis. Solitary lesions, retinal lesions, which we mention in literature as a fog, in the light in the fog, and with the localized vitreal exudation and vitritis with solitary retinal lesions will go into battery of investigations, and especially tuberculosis can be suspected in such cases or young age, and if especially adjacent to a chorioretinal scar lesion, it can be a reactivation of toxoplasmosis. Chorioretinitis, whether multifocal with macular edema or a solitary lesion along a vessel, and here also tuberculosis should be suspected in our countries. This is a child who presented, 10-year-old child, presented with accidental discovery of low vision in the left eye, and he was referred to me for OCT. On OCT, the colored photography, I'm seeing a fan-shaped dense exudation and exudation in the subretinal space along the upper arcade, and with the OCT, there is a subretinal edema with dense exudation in the subretinal space. First, I thought it's a unilateral condition, 10-year-old child. It might be a rare manifestation of Coats disease. So I asked to add fluorescein angiography, but astonishingly, I didn't find anything in the angiography, no telangiectasias, no ischemia, nothing at all in the vessels. So I said, why not to be a rare form of central macular telangiectasia? I tried to do OCT angio, though the child, he was cooperative, but poor fixation with the slight motion artifacts, but definitely there is any telangiectasia in the macular area. So I want to go to, it's a neuroretinitis in a child, which is a rare cause, but it can be present with a single episode or recurrent episodes. And disc edema, unilateral vision loss, dyschromatopsia, macular star of hard exudation, which was very pathognomonic in such a case. It can be infectious, inflammatory, can be viral infection, but Bartonella henseli is very, very common cause, which is a cat scratch disease. And this proved and documented by high IgG and IgM, and he responded dramatically to doxycycline, or it can be taken rifampicin. This organism is a gram-negative organism, which reservoir in cats, and it can cause a single cause of a neuroretinitis in children. And to be reminded that these children will play with cats and street cats, especially, he can be infected. But it causes multiple system involvement, neurological presentation, ocular, pulmonary, cardiac, renal, dermatological. So he should go for all consultations and all body screening because it might affect multiple system affection. As a conclusion, and it's a conclusion of the whole, this fantastic session really, and thanks that I am part of this session, that patients with minimal or even no significant renal lesion, but known to be having vascular collagen disorder, he might be subjected to fluorescein angiography, especially if he's having unexplained vision loss or disturbed vision, because the patient might not express in words his exact visual discomfort. Fluorescein should be thought in any patient with unexplained visual drop of vision, and the role of fluorescein will never be damped, even with the new technology of OCT angiography. In words, I put fluorescein angiography. This is the whole imaging technique for retinal, medical retina. And the retinal periphery explains for us and give the more accurate examination diagnostic. Thank you very much, and it's a chance I would, my pleasure to invite you all to our upcoming ophthalmological meeting in Egypt, the annual meeting of the Egyptian Society. I'm part of the board of the Egyptian Society. Thank you very much and for hearing. Thank you.
Thank you very much, Dr. Nihal, for the wonderful talk.
Especially in Harada, Vokhanagi Harada, you were saying, yeah. Or exudative detachment exactly. As a whole?
No, in VKH. In Harada.
In Harada, yeah. The most common presentation is the posterior uveitis in Harada, but all cases present with this exudative detachment. I don't get you.
You see the Vokhanagi, the bilateral uveitis.
Yes.
Premature growing up your eyelashes. It was confirmed by
OCT and
Harada postulated an exudative detachment. Harada is basically a uveo-meningeal syndrome.
Yes.
And you have got to put up the sympathetic ophthalmia. Harada, sympathetic ophthalmia, sarcoidosis, Behçet's, tuberculosis, syphilis, Epstein-Barr virus. They are the important causes of pan-uveitis.
Pan-uveitis, yes. Yeah.
Do
So,
you experience any deafness in this case?
Deafness? Usually I send the patients for neurological, for the CSF analysis, for the lymphocytosis in the CSF, and for hearing measurement. But I didn't have a feedback of deafness, definite deafness in these patients. But of course, all patients are coming in the acute stage with meningeal irritation.
One of the slides, there is a vitiligo also. That's also a feature of the kind. See that?
Yeah.
The challenge with the vitiligo.
Because is he doing so for the hearing? You mean? Yeah, but the vitiligo, the skin lesions. Yeah. But the skin lesions is a definite parameter of Harada, to be a part of Vokhanagi Harada.
any other questions from anybody? I think it's a very elegant talk on retinal vasculitis. In our country, we see in India retinal vasculitis due to the Eales disease. So, which our institute and others have contributed in understanding by doing the molecular biologic study like PC from the vitreous, epiretinal membrane, and whole eye section. We found majority of the cases that mycobacterium tuberculosis DNA is present in by PCR. So we nowadays tend to avoid the term Eales disease. We try to call it as a tubercular retinal vasculitis, which is a form of Eales disease. Yeah, European countries is.
It's an Asia, South Asian. It's South Asian.
It's the Asian subcontinent we see, Indian subcontinent we see that.
A lot of hypotheses on that. They say that the retinal vessels get sensitized to the toxins of asparagine.
No.
They say that it may be parasitic.
No, that. So now it's thought to be due to the tubercular etiology. Any other questions from any of the topics? Please take the mic. We have got till 9:30. Now it's 9:11.
Thank you. I have two questions. First to Dr. Padma Malini. Yes, very nice story with the uveitic macular edema. My question is, how's your experience with rituximab as an anti-CD20? Because many times I have little experience with rituximab. When we give anti-TNF, it works best. Whenever recur, we think of autoantibody, probably due to in compliance with mycophenolate because methotrexate mostly better with weekly injection. And when we switch to tocilizumab, usually it resolves. Whenever it come back, we think also with autoantibody, and we can switch to infliximab or other biologics. But with anti-CD20, we have little experience. So I would like to know if you have, because you show us with the rituximab treatment.
This particular patient, rituximab, was initiated because of
The
the
mic,
systemic
please.
disease association.
Okay,
So not because for the macular edema.
okay. But it resolved with rituximab or?
He did show partial response, but the response was
Okay.
not satisfactory, so we have to switch over to adalimumab.
Okay, yeah,
We
okay.
don't use that as a first line for the macular edema.
Yeah.
This was because of the systemic disease association was initiated by the rheumatologist.
Okay, thank you. And my second question is to Dr. Mudid. How often did you experience prozone effect? So I suspect that you mentioned with this false negative VDRL, if you do reverse algorithm, and then probably it's prozone effect, and how often do you find that? And are you always doing dilution to get it positive, or you just treat if the clinical manifestation is suggestive, or if it's not specific, how you proceed? I mean, do you always order serial or multiple dilution to get it positive?
Yeah, so the thing is, as far as the multiple dilution is concerned, it's basically dependent on the lab where it's getting done. But as a rule, that's why we get a TPHA done first, followed by a VDRL. So that's how we do it. But yes, as far as the dilutions are concerned, otherwise I'm loud enough, yeah. So as far as the dilutions are concerned, that depends on the lab. Sometimes you do need to tell them about it. Prozone is definitely a possibility. And in around 20% of our cases, we actually noted VDRL being negative initially and TPHA being positive in all of those cases. Occasionally, very rarely, if your clinical index is very strong, you may actually think of getting your test repeated. We have had 2 cases where we were absolutely sure of this being syphilis and nothing else but that. The lab showed us TPHA as VDRL both being negative. We sent the patient to another lab, this time it came positive. That's a rare possibility that's known to occur. So that's why it sometimes becomes important for us to rely on our clinical pointers also.
Okay. Thank you very much.
Anybody had questions, any other questions? Please, go ahead.
I've got a question for Dr. Padmanabhini. So in your case too, you did tear cytokine analysis. Do you generally do that for every patient at every visit, and which methodology do you use?
So this is basically we don't do it for all patients. This refractory cases when most of the drugs failed, I want to make sure that we do it for the academic interest. That pathfinder ELISA kit was developed by her in-house.
Yeah, so like the shimmer strips.
Yeah,
technique.
shimmer strip.
Yeah. So did you did only anti-inflammatory, or did you do pro-inflammatory as well, or how do you decide on your markers? Because
No, this has been preset.
preset,
8
okay,
markers
right.
have been developed in the kit.
Oh,
So we
right.
don't have a
In-house.
choice to choose. So whatever the available 8 markers, we do it.
Okay, thank you.
Do you have any experience about Coats disease? Have you seen any case of Coats disease?
We do see a lot of Coats disease. Yes,
of cases we
the
do.
young children, we get their Coats disease. Quite a lot of exudates in
My
the.
experience about 45 years, I've seen only 1 case.
Oh,
No, we see quite a bit.
Right, we have common.
Dual years, male, leukocoria, diplopia, skin. I don't think that.
These are exudates seen
It's actually-
over that and telangiectasia.
How many cases of Coats you have seen?
So I think it's about 40, 50 cases I've seen.
yes.
Reported in the literature?
Yeah.
And also we
It's
started
all-
seeing adult onset coats as well.
Also,
Sorry?
We are seeing coats in adult cases as well.
adult Coats disease.
Adult onset coats disease.
What is the modality? Did you do a laser or
Cryo.
so they say that if you do this, there's an exudative detachment. This is called like Coats.
Before the stage of exudative detachment, I have several cases that I did for them because they were about 8, 9 years old boys, usually boys. I didn't see in a girl.
Yeah.
Yeah, it is reported.
Boys are infected.
Yes,
Boys,
unilateral.
unilateral.
I did them cryo for 180 degrees in the whole temporal periphery, and they responded dramatically. Even if I preserve the vision of 360, 460 for that child, the exudation in the posterior pole dramatically diminished, and at least I preserved the eye, not going into further complication.
When I was working in the Middle East about country, I saw one case. It was the son of a Pakistani who came with this thing, and the problem with this is that they get a lot of complications, complicated cataract.
Yes.
Crisis has been reported.
And secondary glaucoma, he will go further in secondary glaucoma, and it will be a painful.
They say even if you do a cryo, it might prevent the exudative detach, but improve the vision.
Yes, no, actually, I am documenting it with photography that they improved, and the exudation diminished in the posterior pole dramatically, and even if it's 50% diminished.
Were there other telangiectasia?
Telangiectasia. I didn't do fluorescein for these two cases. I only just photographed because I was impressed with the regression of the exudation in the posterior pole. I didn't actually, but of course it will regress, regressing the ischemia.
Because you can auto or a pseudofluorescence.
Yeah.
So you can do a fluorescence, and a lot of times now that you have got a wide field autofluorescence and fluorescence FFA available, with Optos you will be able to see a lot of these peripheral telangiectasias. Some of them are actually even amenable to a focal laser, which you can do over them. For the exudates that come on the posterior pole, one of the treatment options can be intravitreal Ozurdex. So steroids sometimes work very well in taking care of the exudation that has come at the posterior pole. So it can be sometimes a combination of both a cryo or a focal laser to the telangiectasias and an intravitreal steroid implant.
My only confusion is what the incidence of the scores. Is it very high?
It's not very high, but we do actually end up seeing quite a few of them. Like what Dr. Biswas said, he has seen around 40 to 50. Even we have seen quite a few of them. In fact, one of my colleagues, Dr. Vishal Rawal, who takes care of ocular oncology in our institute, has probably reported a series of around 60 to 70 patients of ocular oncology.
Usually you put it in the differential diagnosis of leukocoria.
Yes,
yeah,
definitely.
Do you have a candidate cataract or blastoma toxin?
All of them, yes.
Coats disease.
All of them.
I'm having a case of she was a girl. About 6 months, and she was coming for me for ultrasonography. And in the ultrasonography, the picture, it was exactly of a vitreoretinal proliferation. I couldn't document a definite mass. So in such a case, I said for RedCam to differentiate and to put vitreoretinopathies in the differential diagnosis. But unfortunately, the RedCam report came to me back that it's a retinoblastoma. But I repeated the sonar, and I can't get a retinal lesion. There was no retinal mass. They decided that this is a retinoblastoma, and for inoculation. I told them, okay, come to me back with the pathology. I won't be convinced except with the pathology. But I lost the patient. But I said at that time, I was so convinced that it might be a rare manifestation of early Coats disease.
The patient was a female?
But she was a girl.
It's very rare.
She was a girl. Yes, Mahid.
Aphasia part 1. Coats disease.
In
sex,
boys, yes, boys.
unilateral and boy.
Yeah, I know.
Okay. So
Please.
I wanted to ask Dr. Jyotirmay sir. So when you recommend where one can omit or skip fluorescein angiography in posterior uveitis cases?
When
One can omit or skip fluorescein angiography?
When it is not indicated.
Okay. Well, so, for example, you know that I don't do routine fluorescent angiogram in VKH cases. So when I see exudative retinal detachment, granulomatous uveitis, nowadays I do that ultrasound and an SSOCT. We don't need to see the starry skies pattern and petal that leak, pooling of the dye in the late phase. So we can avoid.
So usually pregnant females we don't do. That is a contraindication for FFA.
And to ma'am, I wish to ask, where you place diagnosis and management of retinal vasculitis in children, different from adult, evaluation and management? What different you do, or what different you clinically see in your cases?
The difference that the battery of investigation I will go through. If, for example, a child with a posterior pole solitary granuloma, I will go for toxocara and toxoplasmosis. If he's having, I will ask for joint pains, and if his juvenile uveitis, this is a part of the immune complex of uveitis. But if middle-aged, especially if female, I will go for systemic lupus. If an older age group with collagen, I will go for rheumatoid. It differentiates for me the provisional differential diagnosis to reach the etiology or the underlying cause of the disorder.
Thank you.